Good morning. I'm Adrienne White-Faines, and I'm honored to be here today to moderate our panel on understanding the disproportionate impact of COVID-19 on underserved communities. Just 5 months ago, as the virus moved into the waterways of the US, for many in healthcare, the COVID-19 was like the Titanic. And the question was not, will it hit the proverbial iceberg of health disparities in the US? Instead, the question was just how devastating will the casualties be when it hits this iceberg? So today we're honored to have an outstanding panel of healthcare experts to share not only what is this iceberg, but also why is it so unavoidable in this pandemic and given our US healthcare system today. And further, we want to highlight how, with more collaborative approaches, we can begin to dismantle and hopefully destroy this massive iceberg to clear a more equitable and unobstructed path of healthcare, both physical wellness and financial health, for populations all across the US. So I'm honored today to be joined by an outstanding panel, and to maximize our time, we're going to jump right in and hear from our panelists. I'm going to refrain from providing more detailed individual bios and ask that you please reference them anytime on the Emerge website if you haven't already done so. So to begin with, Dr. Donald Schwartz is a Senior Vice President for Programs at the Robert Wood Johnson Foundation. And just prior to taking this role, he was Deputy Mayor for Health and Opportunities and the Health Commissioner for the City of Philadelphia. And in that role, and prior to that role, he also has served in leadership positions in academic medicine, in pediatrics and adolescent medicine, at Perelman School of Medicine at the University of Pennsylvania and at the Children's Hospital of Philadelphia. Don, as a physician and as a public health professional invested in creating a culture of health in this country, can you begin by sharing your initial reactions and observations about the onset and outcomes of COVID-19, especially regarding its impact on vulnerable populations?
Thanks, Adrienne. I have to say that we have been very well aware that if I talk particularly about Blacks or African Americans in this country, there have been a series of what have been called social determinants, factors that affect the health of groups in our country who are have less access, particularly to economic benefits. And we know that for Blacks and African Americans, what that has meant is that they are twice as likely to die than whites in general.
If you will, we're going to circle back and get Dr. Schwartz in on this conversation. But in the interim, while we're straightening out the Wi-Fi, I want to turn to our panelist, Dr. Brandy Kelly-Price. And Dr. Kelly-Price, you currently serve as the Director of Programs at the Humana Foundation in Louisville, Kentucky, and you direct the foundation's health equity research and strategy for their $65 million in investments. So before joining the foundation, you were also the director of the Louisville Metro Center for Health Equity, with a joint appointment at the University of Louisville School of Public Health, where you still teach, and advancing your scholarly work on the intersections of health equity and social impact. Brandy, from your lens, and can you share your initial thoughts, and then we'll circle back to Dr. Schwartz.
Thank you so much, Adrienne. And, I'm really excited to be on this panel because I think initially what I was thinking about COVID-19 is that I am so excited in some ways that we are going to have an honest conversation in our country as it relates to the social determinants of health. It is a devastating disease that has ravaged our world, a devastating virus that has ravaged our world and even economically has created upheaval. But as we've seen over the past 3 months, as it relates to the virus, as well as it relates to police and brutality in our country, there has been a systemic issue. Structurally, structurally, we have faced an issue throughout the starting of this country for African Americans and Blacks, as well as Black individuals in our country, as well as for other people of color, whether that be our indigenous populations, our Asian Americans, or our Latinx populations. And so where we're seeing the disparities, particularly among the mortality rates as it relates to COVID-19, is not surprising. I think what has been surprising, and it's not surprising because of our life expectancy gap. It is not surprising because of our morbidity and mortality rates due to diabetes and respiratory and heart disease throughout the country. So, I think that's what we were hearing a little bit from Dawn in terms of those actual numbers as it relates to the disparities. And this was happening well before COVID-19 hit, and obviously is going to be exacerbated through the pandemic. One of the things that I think is really nuanced about this moment, though, that I want to make clear is that we are seeing a structural issue, not as it relates to race, but as it relates to racism. So it is the context in which people are engaging in the structures around them. There is not a genetic factor or a biological factor that creates the color. The color of my melanin is not connected to my biology, so to speak. And so what we really have to consider is, how are we going to have a hard conversation or address the hard truths in America in terms of the impact of how someone interacts with their structures or with their systems around them, whether that be police, the healthcare system, the economic system, and the racial wealth gap that we're seeing. And that racial wealth gap has been building over time. It is, I know we'll get further into it in terms of the conversation, but when we're really looking at this issue, not only are we talking about what is going to be the impact on life years lived and quality of life, but we're also talking about what is the economic upheaval in communities. And when before we were seeing probably about 17%, or when we were seeing ownership for the different racial groups, I'll just use the Black and white racial gap as an example. There's been a 17% loss in white ownership in terms of businesses. There's been over 40% loss in Black ownership in businesses. And so how is that really impacting the financial health of not only that individual, but their communities as a whole? So I'll stop there for now.
Wonderful. Thank you so much. And you've given us some meat, and we're going to go into many of these issues in just a moment. Our third panelist is also, as I'm here in Chicago, I'm pleased to introduce Darlene Hightower, who also viewed the pandemic from the eye of the storm here in Chicago, while she serves at Rush University Health System, where she's a vice president for community health equity and engagement. With oversight in that role, she has oversight of implementation and evaluation of community programs, including school-based health clinics and community outreach programs, such as the Cradle to Career Healthcare Pipeline. She has extensive involvement in a variety of community activities in underserved communities in Chicago, and also was recently named as the Robert Wood Johnson Foundation's Culture of Health Leadership Fellow. So, Darlene, can you jump right in here and share your initial thoughts and perspective with us on COVID-19?
Sure, happy to, Adrienne. Thank you for that introduction. So I want to bring a little bit of local numbers and flavor to this conversation. Here in Chicago, we've had about 2,500 deaths from COVID-19. I just looked at the data today from the Chicago Department of Public Health. 75% of those deaths have been African Americans or Latinx residents in Chicago. We talked a lot about that not being surprising, that these communities are hardest hit What I'd argue, though, is that it's unacceptable. Like, we've known for years that Black and Brown communities are vulnerable when it comes to economic investment, educational outcomes, health outcomes. So no, the fact that COVID-19 has hit these communities hardest is not surprising at all. The fact that we allow this kind of stuff to continue to happen, that is what's shameful. So I talked a little bit about death rates, but when we talk about incident rates, and when you look at January to date, the Latinx population has gotten COVID-19 at rates that are twice as high as everyone else in this city. Again, why is that happening? What is it that we're going to do about it? I think now there's an opportunity for us to finally do a deeper dive into what Don was initially starting to talk about, the social determinants of health. Because from my perspective, these communities are vulnerable and we have poor health outcomes because of poverty. And I'll just be bold and say poverty kills. We know for a fact that higher educational attainment, higher quality jobs, and higher incomes means that you will have higher or better health outcomes overall. So if we know that to be true, what are we doing as a city, as a state, as a country to get at the economic and educational factors that are causing the type of health disparities that we're seeing now? Because the reality is, yes, we're going through a pandemic right now, hasn't happened in the last 100 years, but in Chicago, we also went through the 1995 heat wave. Who died from that? Poor African-American people in vulnerable communities. We went through the AIDS crisis in the 80s. Who died from that? People of color died from that as well. So we're seeing history repeat itself just in a different form. Now is an opportunity for us to address it and be honest and real about why these populations are continuing to suffer from disease at higher rates than others. And I'll stop there.
No, thank you so much, Darlene. We're going to have a lot of meat for our conversation. Don Schwartz, can you chime in?
So the only thing I would add, I think my colleagues have very nicely summarized. What we have seen that is not terribly surprising is just how disproportionate things have been. So we know, for instance, that in terms of folks on Medicare, there's 4 times the number of African Americans being hospitalized in terms of a rate of hospitalization compared to others. And that disproportionality goes across all aspects of healthcare need. But unfortunately, we also know that healthcare insurance has not met need. So because African Americans and Blacks particularly have been employed in essential services, they are being put at risk. But those who are African American or Black who have been employed in those services have been much less likely to be covered by insurance or eligible for insurance when they lose the job. And so we have a lot of folks who are particularly at risk and particularly ill who don't have access at the moment to insurance. We're even more worried that we're seeing rises in rates of people who are uninsured without a good response to help provide people with that insurance. And it's even worse if folks live in states that haven't expanded Medicaid, which we can talk more about later. Thank you for your patience.
No worries, no worries. What I'd like to do now is actually take this just a layer deeper. So you all have done a terrific job of giving us a wonderful and broad overview. You've mentioned things about access, insurance. You've mentioned issues on income and neighborhood designation and the results of segregation. We've mentioned racism. We've mentioned issues around need for services. So let's take this one step further. And I'm going to start with Darlene. So Darlene, the data has indicated that the impact of COVID-19, some of the possible causes are likely to be further exacerbated because those that were hit were essential workers, particularly in minority and underserved communities. What the real reference here is that there was a real economic hit and a real tie between financial equity and health equity. Can you highlight what your learnings are and what you'd like to share with us about the issues of employment, workforce, income, et cetera, and its impact on health outcomes?
Sure. So as you were talking, one of the things that came to mind is most of us were under shelter-in-place orders beginning in March. And they're just recently starting to lift here in Chicago. And if you were fortunate enough to have a job where you could work from home, it was inconvenient, but you took your laptop and you carried on and you did the work that you had to do. But that's a privilege. And not everybody has that ability to be able to work from home and use a laptop and still be productive and get things done. What we found is that a lot of people of color, both Black and brown, did not have that privilege, did not have the ability to be able to stay at home and shelter in place. They had to get up every day and go to work. They were bus drivers, or they worked in places where they had to get on public transportation to do what we call essential work. And so you're seeing differences in economics and then therefore differences in who's being affected by COVID, because some people did not have the ability to stay at home, to shelter in place. They had to be out. And so then it's not necessarily surprising that as a result of that, because people were out and, exposed and basically just trying to earn a living, that they are then vulnerable and suffering from incidents of COVID-19 at rates that are higher than others.
Thank you. Thank you. I'm going to ask Don to pick up from there and talk to us, go back to your experiences from Philadelphia as the Commissioner of Health, and talk to me about the life expectancy gaps and how how zip code can determine your ability to succeed, survive, or thrive when a pandemic such as this hits.
Yeah, thanks very much. I have been aware for a long time of the disproportionality in terms of life expectancy in cities like Philadelphia. Philly is the poorest of the largest cities in the country. And so that set of impacts that come from poverty in the city and poverty in places in the city disproportionately affect the health of people. So if you're an African-American man in Philadelphia, your life expectancy is on average 25 years less than, for instance, an Asian woman. It's enormous. And if we look by neighborhood, so downtown in the central part of Philadelphia, which is largely white and largely affluent, people live on average 87 years. And in North Philadelphia, which is largely folks of color who are poor, the average life expectancy is 64 years. Mm-hmm. So disparities are huge. And we know that place makes a difference. So where you live affects what you eat, what transportation you have, where you go to school. It's fundamental in this country. And we're seeing that play out everywhere in terms of COVID. So for instance, in the counties in this country where the largest proportion of people who are African American live, those counties are places with the highest rates of COVID deaths. The impact of place and all that place means both for policy and for access and for the impacts on health and the ability to be healthy, it's profound, and it plays out in Philly as it does, I know, in Chicago and the other places that folks who are part of the panel live in.
And Don, to that point, I mean, what many often forget is that those places, those zip codes, those locations are actually were intentionally designed many decades ago to steer those communities to those zip codes. Therein lies, they began to grow and fester and create the very disparities that you speak of. But it wasn't that people chose to end up there. So Brandy, can you jump in? One of the things that's happening is in this discourse, in this elevated visibility of disparities and the challenges of health inequity, we're also finding ourselves in the midst of a massive visible display of the impact of racism on populations. and the connection between our healthcare institutions and the identified systemic racism is bringing forward many providers to come out and proclaim that systemic racism is actually a public health crisis in and of itself. Can you talk to us more about how this is and what are the ties that the healthcare community makes around these types of issues? And maybe Darlene, you want to jump in after, because I know your institution signed on to such documentation. Brandy, can you pick it up for me?
Sure. Well, thank you. You know, and I want to, I think it's really interesting when we think about how public health is making this stance right now. So we hear that from the American Medical Association, the American Pediatrics Association. And so thinking about, you know, this is affecting our children, no matter what race of the child, this is affecting and has affected the life expectancy of individuals since, as I said before, since the starting of this country. It's really amazing to see some of the early writings before the 1900s by Black physicians that were talking about the impact of not only slavery, but the impact of racial inequities on the life expectancy of African-American individuals in this country. So I don't think it's a new dynamic, and I think this is something that we're actually saying. Working at the Humana Foundation, so we're the 501c3 arm of Humana Inc., we do take a stance of being an anti-racist organization. We are very clear of how we want to co-create with communities. We're very clear that we need to disaggregate our data by the different communities that we're serving, and let's really try to systemically address the inequity in that community. Because as you said before, Darlene, we know that this is not something that has just come to be. This was an intentionally created issue in our structure of our country when we're talking about the policies and the ways in which places were designed and constructed. We see everything from redlining that happened in communities all throughout the country in terms of how banks and grocery stores are deciding where they're going to go today based off of some of those maps that were legally put into place back in the 30s. The GI Bill, the evictions, the exclusion, all of these are policies that come into place. And so when Don is talking about place matters and zip code matters, what we also know as it relates to racial inequities is what Brookings put out, probably back 2016. They talked about the multi-dimensions of poverty, or the multi-dimensionality of it. And so it's not just income, as often, you know, having conversations about poverty, it also oftentimes would get conflated with just one being low income. But it is a matter of, may choose 5 dimensions, but having health insurance was one of those in terms of, are you able to pay for your health care? And even living in an area where there are 20% or more who are living below the federal poverty line. So I might have the highest income, I might have health insurance, I might have opportunity for home ownership, but because of the area itself and that access within that area and the other individuals who do not also have high wealth, that is going to cause a lower rate of economic and financial growth for me as well. So I think, you know, we need to have this very holistic conversation, and that is one of the conversations that we are having at the Humana Foundation in terms of the investments that we're making, knowing that it has an impact on not only someone's lifelong years or their life expectancy, but how healthy is their day going to be today.
Yeah,
Absolutely.
I'm just like
right.
chomping
Darlene,
at the bit to jump
go ahead,
in on
Darlene.
this. Because I've been thinking so much about what you just mentioned. A couple folks have mentioned about redlining, and how that has such an impact on health outcomes. So this is a practice that started in the 1930s and like legally ended in the 60s, right? You're not supposed to redline neighborhoods as bad or good and then base economic investments on them. But the reality is that that is still happening today. There was an article that came out with the WBEZ that looked at who's lending in these neighborhoods from 2012 to 2018 in the Chicagoland area. And what it found was that 68.1% of the dollars that were loaned for housing purchases went to majority white neighborhoods, while just 8.1% went to majority Black neighborhoods. And what that means is that for every dollar invested in white neighborhoods, only 12 cents was invested in Black neighborhoods. And that matters, like mortgages and home ownership, as Brandy said, it matters because that dictates if you've got businesses in your neighborhood, viable businesses, viable grocery stores, is your community walkable? All of the things that we know make for a healthy, vibrant life. So the redlining thing is real. It continues to impact our neighborhoods. I could talk about what we're doing about it, but I'll stop.
I'm gonna hit you with that just a minute. Darlene, you talked about solutions. And I think the one thing that we all are learning is as we go through these very difficult times, it is essential that we learn from these times so that we not make the same mistakes and carry on and perpetuate the inequities. Talk to me, all of you, as I circle through, to share some of the things you are doing with your organizations. And I think we'll start, Brandy, why don't we start with you?
Sure. So, as I mentioned, we were making investments in the social determinants, and really being clear in terms of that everybody is experiencing some determinant of their health. It is not only those who are experiencing poor health. So we were investing in those before the start of COVID-19 in 4 particular areas: food security, employment and income, financial asset security, and education. And then one that I think is, all of them excite me, but one that really has me interested in how do we actually get to what we're trying to change in our country, the actual determinant of our health, is the social connectedness, and how are we shifting the landscape of our communities based off of a citizenry and who is connected and how can they be connected, and why. And so those are our 4 areas that we focus on. But I think more specifically, since COVID-19 hit, it was exciting to have a gift from Humana Inc. to the foundation and to work in partnership in terms of what are we going to do to address what needs to happen now in communities. And that is everything, as I was talking about before, from building deeper level infrastructure. I know our parent company has invested in the infrastructure of a zip code in our community here in Louisville, our hometown, in terms of where the Louisville Urban League is building a learning and track complex and a $50 million project to really help to raise the infrastructure of the community. And so we, as the foundation, we've come alongside and we're saying, we know that poverty is more than just about one's income, but we are really going to work on workforce development. We are really wanting to build the trust and transparency in the way in which we talk about living wages in our community. So we've supported the National Domestic Workers Alliance, and we are really thinking about One Fair Wage as also a partner that we wanted to invest in. And I think prior to that, we were intentionally investing in our Metro United Way that had a financial literacy program. It goes so much further than financial literacy, and education. But what Metro United Way was doing, which I think is really our systems level change that we're pushing for, is how do we have greater context around the census and really doing advocacy efforts in terms of what money is lost in a community when there are certain individuals that are not counted in that community. And so that is one of our systems level change that we have in our partner Metro United Way with their XLU rate program. So I'm really looking forward to us going deeper. We have not changed it yet, and nor will we change systemic and structural racism with philanthropic dollars. It is going to take a multi-sectored approach, but I'm enthusiastic about the path that we can be on when we're really willing to face the reality of where we've come to this moment and who has been privileged to get here and who was not.
Great, great, thank you. Don, I see you moving, so I'm going to grab this moment. Lots I'm sure you want to say. I'm just going to let you jump right in.
I'll try to be quick. I apologize for the instability. I will say that the Robert Wood Johnson Foundation has been focused on this whole area of social determinants now for almost 6 years. And so when COVID hit, it was a good time for us to double down. We've done things that may be unexpected for a health foundation, like we're increasing the number of guarantees that we're willing to provide to institutions that are helping to assure that African American and Latino-owned small businesses don't go out of business with bridge dollars. We're supporting institutions that are helping folks think about how do we bring affordable housing to places that may have been the subject of redlining, so that people can, in this moment, do what's necessary to assure that affordability increases. We're doing a lot of work that we've done for a long time on health insurance. We're aware that at the moment, if you become uninsured in a state that hasn't expanded Medicaid, you are almost twice as likely to stay uninsured. Medicaid expansion has substantially both reduced the likelihood of uninsurance, and it has improved the health status of people in the states where it has occurred. And at this moment, it is an essential service, a financial service for people, because those who get COVID and require healthcare services in states without expansion, those folks are going to be hit with healthcare bills, and those bills are going to go unpaid if they don't have a job and a financial resource, and their credit will be affected. It will affect all of us. And it will only make the health status of people in communities already challenged that much worse.
Before I flip over to Darlene, I just want to engage Don. You, Brandy mentioned a conversation about the importance of data. And as we talk about the integration of financial platforms for equity and health, one of the things that COVID did reveal is how replete we are in this country of really understanding how to integrate appropriate data. Can you just give us a tidbit, and then I'm going to let Darlene close us out.
I can just say that we are mightily investing, and we are partnering. Although people are not happy with the CDC is working very hard with states and others to try to use this moment to improve both the data availability so that when new waves of COVID hit, we're ready. And it's also focused on helping states report by disaggregated categories so that we can track the epidemic among people who are most impacted, who did not get identified well in the early stages of COVID.
Yes. So Darlene, you're deep in this work and have done some amazing things for the West Side of Chicago. Share with us your views, your vision. What do we all need to know about what it takes to make this a success going forward?
That's a really great question. And as everyone was talking, I'm thinking to myself how big and intractable these challenges and issues are. We're talking about things like poverty and economic disparities, these like structural things. And when you look at it from that perspective, it can feel daunting. But my advice to any organization or people that are watching is to use what's in your hands. What is available to you right now as an institution, an organization, an individual to be able to help. And so for Rush, we are the largest private employer on the West Side of Chicago. We've been on the West Side for 180 years. We're an economic engine. And 5 to 6 years ago, we woke up to how do we use that economic engine to really positively impact our West Side neighbors. And what we've done is kind of claimed our anchor mission or our anchor status by putting in place an anchor mission where we are hiring locally and developing career paths when people come into our doors as employees. We are, when we build buildings and other capital projects, making sure that there's a local presence in who's working on those projects. When we're buying things, which, you know, we have a big supply chain, making sure that the folks that are in that supply chain are small businesses from the West Side. we've been doing social impact investing. So taking a look at what are the economic development projects that are happening on the West Side and how can we invest in them through CDFIs. And then lastly, how are we marshaling our employees? We have 13,000 of them, and investing their time, talent, and treasure intentionally on the West Side. So that's what we're doing as an institution. And the last thing I'll mention is we were one of the catalysts for an organization called West Side United, which brings together 5 other health institutions that are also wearing their anchor mission hats and doing the same kind of buy local, social impact investing, hire local, and career pathways.
You all are an absolutely outstanding panel, and I can't thank you enough for your cooperation and fluidity to get us through this conversation. America, as you know, is reeling right now from multiple crises. But as each one of you have pointed out, this is a unique time to say no more. And let's take innovation, let's take collaboration, let's work across channels, let's be disruptive, and let's come together to see if we can't break this iceberg down once and for all. Thank you, all of you, and thank you, Emerge, for the opportunity for this wonderful conversation.